The first one is Elwood Jensen, who is credited for discovery of the estrogen receptor in 1958. Craig Jordan for discovery and development of tamoxifen. Bob Weinberg for discovery of HER2. And then finally, Dennis Lehman for development of trastuzumab. And it's because of these folks that we have triple-negative breast cancer. So triple-negative breast cancer is a receptor-based classification. It was essentially developed to define tumors as tumors that do not express ER, PR, and HER2. And so it's not surprising that it was first used in October of 2005 when we had endocrine therapy as well as trastuzumab. And it's a very popular classification. If you do a PubMed search, I did it yesterday. As of January 2022, there are more than 10,000 articles, so more than one article a day about triple-negative breast cancer. So let's start with a patient story. I'm a medical oncologist. This is a patient I had seen in clinic a few years ago, 44-year-old premenopausal female. Notice a lump in her right breast, and an ultrasound mammogram confirmed a 4-centimeter tumor, had a biopsy which showed poorly differentiated carcinoma, ER/PR, HER2 negative. So the first question to consider for this 44-year-old patient with triple-negative breast cancer is whether you would do neoadjuvant therapy or upfront surgery followed by adjuvant therapy. A landmark trial by the NSAPB group essentially asked this question. For a patient with breast cancer, if you give neoadjuvant therapy versus adjuvant therapy, are the outcomes different? And essentially, this trial showed that the outcomes are the same. The disease-free survival is essentially the same whether you use neoadjuvant therapy or adjuvant therapy. However, there are several advantages of neoadjuvant therapy, and more, the field is moving towards neoadjuvant therapy for a patient with triple-negative breast cancer. And the reason for that is neoadjuvant therapy has several advantages. It can improve the rate of breast conservation therapy. So for a patient who is not a candidate for breast conservation therapy, with neoadjuvant therapy, you could shrink the tumor and increase the probability of breast conservation therapy. The second advantage is that it can allow for assessment of tumor response to therapy, almost like an in vivo model where you can see for an individual patient if the patient's tumor is responding to therapy or not. And from a research perspective, it can help identify predictive biomarkers. And then finally, the response to neoadjuvant therapy could guide adjuvant therapy, because we know that presence of pathological complete response portends a good prognosis, or presence of residual disease portends a bad prognosis. And we'll review this concept again later. So coming back to this patient with T2N0 clinical triple-negative breast cancer, the plan was formulated for neoadjuvant therapy. Now, the next question to consider is what neoadjuvant regimen would you use? We'll wait for a minute or so. You can decide which therapy you would consider. ACT or TC or ACT with carbo or ACT with carbo and pembrolizumab or a clinical trial. You can also type your answer via the chat.
Recording in progress.
We'll give a few seconds for you to send your answers. Well, clinical trial is never a wrong answer. There are all reasonable options depending on the era. In the current era, I would lean more towards D, and we'll review that. So a few years ago, the landmark CLGB 40603 trial asked this question: if you add platinum to ACT, would that result in better outcomes? And essentially what it showed is that you can improve the pathological complete response or PCR rate with the addition of carboplatin, but you also have higher toxicity. But this study did not show any improvement in event-free survival with the addition of carbo. A limitation was that the study was underpowered for evaluation of event-free survival. In terms of side effects, in particular, neutropenia and thrombocytopenia, the incidence is much higher with carboplatin. But then the landscape changed last year. At the first ESMO virtual plenary session, Peter Schmid presented the updated results from Keynote 522, a phase 3 trial looking at neoadjuvant pembrolizumab plus chemo versus placebo chemo, followed by adjuvant pembro versus placebo for patients with early stage triple negative breast cancer. About 2 years before that, Peter Schmid had presented the first results of Keynote 522, where it was demonstrated that with the addition of pembrolizumab, you have an improvement in PCR. In the control arm, which was AC carbo plus Taxol, the PCR rate was about 50%, and it improved to 64.8% with the addition of pembro. However, at that time, the question was, does it really improve survival? Yes, PCR is better, but does it really change patient outcome in terms of event-free survival? So the FDA did not approve the drug just based on improvement in PCR. We were all awaiting the results of event-free survival. So this is what was presented at the virtual ESMO plenary. The trial was positive. It showed that the addition of pembrolizumab is associated with an improvement in event-free survival, not just PCR. If we look at the two subgroups, in patients who have PCR and in patients who have residual disease, you could see that in particular, patients who have residual disease have an improvement in event-free survival. The event-free survival without immunotherapy was about 56%, so close to 50%. Half of the patients would have disease recurrence. And this improved to 67%. So 1 out of 3 patients would have disease recurrence with the addition of immunotherapy. So this is clinically meaningful and was statistically significant as well. If you look at patients who had PCR, that is where things get controversial. There was a slight improvement in event-free survival with the addition of pembrolizumab, but whether that's clinically meaningful or not remains to be determined. So the use of adjuvant pembrolizumab in a patient who has PCR is currently controversial. So coming back to this patient received neoadjuvant therapy. This was before the Keynote trial. So the patient received standard ACT and then had surgery, then had residual disease after surgery. Now the question is, what therapy would one consider next for this patient? No therapy, adjuvant platinum, adjuvant Xeloda, adjuvant bevacizumab. Again, you can think about the answer, send in your answer via the chat function, and then we'll proceed forward. I'll wait for a few seconds. Okay, let's move forward. For this patient, I would lean towards C. And the reason is, first, let's understand the difference between PCR and residual disease. Multiple studies, including a meta-analysis, has demonstrated that the presence of residual disease is associated with worse outcomes as compared to patients who have PCR. The 5-year event-free survival is close to 90% in patients who have PCR versus 60, 65% in patients who have residual disease, depending on the context. Even in triple negative breast cancer, we see the same trend. Now, there are a couple of things to note. First is that PCR does not mean 0% risk of recurrence. And this is the point that some have made about giving additional therapy despite PCR, is that yes, the outcomes are 92 or 93%, but can we even make it better to 96, 97, 99%? And on the other hand, no PCR does not mean 100% risk of recurrence. There are still patients who have residual disease who would never have disease recurrence for the rest of their life. But that's where the role of adjuvant therapy comes in. We know that patients who have residual disease have higher risk of recurrence. So can we add adjuvant therapy in a patient who has residual disease despite neoadjuvant therapy and then improve outcome? And that's why the neoadjuvant model is a good model, because you start with a certain therapy, and then depending on response to neoadjuvant therapy, you can select the use of adjuvant therapy. And this is exactly what was done in the CREATE-X trial, where patients who had residual disease after standard neoadjuvant therapy received capecitabine versus no therapy. And the trial showed that patients who received capecitabine had better outcomes. And this has changed the standard of care. And currently, adjuvant capecitabine is recommended for a patient who has residual disease after neoadjuvant therapy. How about platinum? This was a question that was investigated in a cooperative group trial in the US, where patients who had residual disease after neoadjuvant therapy received adjuvant capecitabine versus adjuvant platinum. And essentially, the trial was negative. It showed that there was no improvement in event-free survival with the use of platinum rather than capecitabine. So capecitabine remains the standard of care. Now, we looked at this patient, but one option to consider is what's the BRCA status? Because the BRCA status could impact the choice of adjuvant therapy. And the reason being that we have results from the Olympia trial, which demonstrated that the use of adjuvant olaparib is associated with improvement in outcomes in patients who have residual disease after neoadjuvant therapy. And that's something that's recommended as per ASCO guidelines. So summary in terms of take-home points for localized triple-negative breast cancer. The first point is that TNBC essentially is a diagnosis of exclusion in a receptor-based classification. Currently, chemotherapy is the mainstay of management of triple-negative breast cancer, and neoadjuvant chemotherapy is generally preferred over adjuvant therapy. Neoadjuvant immunotherapy in combination with chemotherapy is the new standard of care for patients with localized triple-negative breast cancer. The role of neoadjuvant platinum continues to remain controversial. For a patient who has residual disease after neoadjuvant therapy, adjuvant capecitabine with without pembrolizumab is recommended. For a patient who has residual disease along with known germline BRCA mutation, adjuvant olaparib with without pembrolizumab is recommended. And finally, the role of adjuvant pembrolizumab in a patient with pathological complete response after neoadjuvant chemoimmunotherapy is currently controversial. So moving on, let's talk about metastatic triple-negative breast cancer. Case of a 35-year-old female who underwent lumpectomy, radiation therapy, received standard therapy with ACT, but unfortunately then had pulmonary metastases. The question is, what would be your recommended therapy for this patient who has disease recurrence despite standard therapy? This patient has BRCA, germline BRCA mutation. So for a patient with germline BRCA mutation, we would consider a PARP inhibitor. And the rationale is fairly simple. In a patient who has a patient who has homologous recombinant deficiency, the tumor is dependent on the PARP pathway. And so when you have BRCA loss, because the tumor is dependent on the PARP pathway, if you block PARP, you have synthetic lethality. In the pivotal phase 1, phase 2 trials with olaparib and talazoparib, response rate was seen with single agent PARP inhibitor in patients with germline BRCA. So this provided first proof of principle that these agents could have efficacy. And we'll come back to this point later on as well. Often you can see in a phase 1, phase 2 clinical trial, if you're seeing evidence of responses, that provides a signal that that could be an agent that would be efficacious subsequently. And there was a race between different PARP inhibitors, and inaparib was the one that was ahead. However, the trial was negative, and it later on turned out that inaparib is not a PARP inhibitor. But then the Olympiad trial demonstrated that olaparib was a standard of care chemotherapy. Olaparib is clearly better, improvement in progression-free survival with a hazard ratio of 0.58. Similarly, talazoparib better than standard chemotherapy for patients with germline BRCA mutation. And this led to the approval of both olaparib and talazoparib for a patient with germline BRCA mutant metastatic breast cancer. So make a slight change in the patient, the same patient, but the patient does not have germline BRCA mutation. So what would you consider? Carboplatin, eribulin, paclitaxel, or capecitabine? And this is a patient who had received ACT previously. Well, the answer is it depends, because we need one additional piece of information, which is whether the patient has PD-L1 positive or negative tumor. So this patient had PD-L1 positive tumor. And for a PD-L1 positive triple negative breast cancer, we would recommend the use of immunotherapy pembrolizumab based on the results of the Keynote 355 trial, which showed that for patients with PD-L1 positive triple negative breast cancer, there's an improvement in progression-free survival as well as overall survival with the use of pembrolizumab with chemotherapy. And the choice of chemotherapy could either be a taxane or platinum. In terms of subgroups, all the subgroups derive benefit. And in November of 2020, FDA granted approval to pembrolizumab for PD-L1 positive triple negative breast cancer. So we reviewed how we can target the immune microenvironment in triple negative breast cancer. The other approach is to target genomic drivers and signaling pathway. We reviewed PARP inhibitor. The other that has been of interest has been the PI3 kinase pathway. And this was based on the results of a randomized phase 2 trial, which showed that the addition of an AKT inhibitor, ipatasertib, can be beneficial for tumors that have altered PI3 kinase pathway. So a phase 3 trial was done looking at AKT inhibitor for PI3 kinase altered triple negative breast cancer. Standard randomized phase 3 trial, but unfortunately the trial was negative. It did not show any improvement in outcomes with the addition of the AKT inhibitor for PI3 kinase altered metastatic triple negative breast cancer. Again, highlighting that we need randomized phase 3 trials before we change practice. Sometimes we can be fooled by randomized phase 2 trials. Obviously, there's ongoing work to identify biomarkers and also to look at overall survival. So coming back to this patient had metastatic triple negative breast cancer, received first-line therapy with carboplatin plus pembrolizumab, worked for a while, then received capecitabine, then had disease progression. Now the question to consider is what to do next. How do you sequence the different therapies, and what should be the next therapy for this patient with metastatic triple negative breast cancer? The landscape has again changed, and there's a lot of interest in antibody drug conjugates for patients with triple negative breast cancer. The idea of an antibody drug conjugate is similar to that of a Trojan horse. You have an antibody with a payload linked to it. The antibody binds to an antigen that's overexpressed in cancer cells, gets internalized, releases the payload to the cancer cell, which causes apoptosis. And newer antibody drug conjugates also have the so-called bystander effect, wherein the payload can also go in the tumor microenvironment and even impact cells that do not express the antigen. So if there's antigen heterogeneity, if there's TROP2 heterogeneity, the antibody drug conjugate would still work because of the bystander effect. An example of an antibody drug conjugate is sacituzumab govitecan. It's a first-in-class TROP2 antibody drug conjugate. TROP2 is overexpressed in all subtypes of breast cancer, including triple-negative breast cancer. Sacituzumab govitecan has an antibody directed against TROP2, a hydrolyzable linker, and the payload is SN38, a topo-1 inhibitor, the active metabolite or the active payload of irinotecan as well. In the pivotal phase 3 trial in patients with metastatic triple-negative breast cancer who had received prior lines of therapy, the use of sacituzumab govitecan was associated with improvement in both progression-free survival and overall survival as compared to standard chemotherapy. A hazard ratio of 0.41 for progression-free survival and 0.48 for overall survival. Patients who received standard therapy on an average had overall survival of 6 months, and this doubled to 12 months with the use of sacituzumab govitecan. And this led to the FDA approval of sacituzumab govitecan, the first antibody drug conjugate approved for metastatic triple-negative breast cancer. But how do we move the field forward? It's good to have a response rate of 30-35%, good to have overall survival of 12 months, but how can we move that to 18, 24 months, and how can we lead to further improvement in outcomes? I think the answer is combination therapy. We need to identify patients who have some response but not complete response, and then use another drug to further deepen the responses. One example related to sacituzumab govitecan would be the use of a PARP inhibitor. Sacituzumab govitecan has a topo-1 isomerase payload, SN38. And that causes DNA damage. So if you use an agent which prevents the repair of DNA, like a PARP inhibitor, that would have synergistic effect, very similar to what's seen with the PARP inhibitor in tumors that have BRCA loss. So there would be synthetic lethality with the use of an antibody drug conjugate with a topo-1 isomerase payload and the use of a PARP inhibitor. So there's an ongoing trial at our institution looking at this combination of sacituzumab govitecan plus PARP inhibitor. The other thing to consider is that with these antibody drug conjugates, the activity might not be restricted to triple-negative breast cancer. The drug was first developed in triple-negative breast cancer, but TROP2 is also expressed in hormone receptor-positive breast cancer. And in the phase 1, phase 2 clinical trial, responses were also seen with sacituzumab govitecan in patients with hormone receptor-positive breast cancer. And this has led to the pivotal TROPiCS-02 trial looking at sacituzumab govitecan was a standard of care therapy for patients who are hormone receptor positive and have received prior therapy. The trial has completed enrollment, and we should be seeing results of this trial later this year. Now, besides sacituzumab govitecan, there are a number of other antibody drug conjugates in development. Datopotamab deruxtecan is another TROP2 antibody drug conjugate. Trastuzumab deruxtecan against HER2. Ladiratuzumab vedotin against LIV1. So the point being, there are different antigens that are there are different antibody drug conjugates that are targeting different antigens in clinical development. So in conclusion, if we look at the management of metastatic triple-negative breast cancer, the first-line treatment currently is chemotherapy plus pembrolizumab for a patient who has PD-L1 positive triple-negative breast cancer. In the second line and beyond setting, for a patient with BRCA mutant metastatic triple-negative breast cancer, we would recommend the use of a PARP inhibitor, olaparib or talazoparib. Sacituzumab govitecan is the preferred second-line and beyond therapy for patients with metastatic triple-negative breast cancer. Standard chemotherapy such as capecitabine or eribulin could be used after sacituzumab govitecan in the third-line and beyond setting. But there are multiple antibody drug conjugates in development to target the different antigens overexpressed in triple-negative breast cancer and breast cancer in general. So the landscape is likely going to change with the use of these antibody drug conjugates. And the final point I would make is the triple-negative breast cancer terminology. Let's think about this. What should we call PD-L1 negative triple-negative breast cancer? Should we call it quaternary negative breast cancer? And what if there's another actionable alteration that pans out? Then should we call the tumor that does not have all those antigens penta-negative breast cancer? And then we can go on and on, octa-negative breast cancer, and so on and so forth. So the point is that currently triple-negative breast cancer is based on what it does not represent. And in the future, we should probably think of an objective definition based on what it represents, based on either tumor biology or a functional classification. So my prediction is in the not so distant future, we'll have to rethink the triple negative breast terminology and use a different terminology based on what's present rather than what's absent in breast cancer. Thank you so much for your attention.